The paper topic is a bit morbid, but as an empirical science, we look at what's actually happening to people, even if it is a bit unpleasant. So the basic data in the paper are from the Center for Disease Control's online tool for tabulating death certificates. You can look at the underlying cause of death on those certificates as well as other contributing factors cited on them. Now, suicides are included in this picture, figure 2 from the paper. You might say no news is good news with that series, which I divided by 3 just to keep it out of the way of the others, which are going to be the focus of the paper. But also we may think about these other series differently when we know that suicides did not increase in 2020 and 2021. The other series are drug and alcohol related. The green series shows deaths from alcohol-induced causes, which includes acute alcohol poisoning, but also deaths from chronic alcohol-related liver disease. By the CDC's convention, it does not include drunk driving accidents, although their tool does permit you to tabulate those separately. The black and blue series here are deaths with drugs found, separately for findings of narcotics and findings of psychotropics. Narcotic deaths are almost all involving opioids of one type or another, although technically narcotics also includes cocaine, LSD, and cannabis as well. Deaths involving psychotropic drugs are primarily involved what's commonly known as crystal meth. You could add the 3 drug and alcohol series to get a total. Now, if you did that, some of the death certificates would get counted twice because they cite instances of both narcotics and meth. But others would be missing because together a number of certificates only cite unspecified drug. So in fact, the two are close to cancel for the purpose of calculating total death certificates. And if you're wondering, only a tiny fraction, very tiny fraction of the death certificates here cite COVID-19 as one of the multiple factors. My purpose is a bit different, which is to look at substance demand. So if somebody participates both in a narcotics market and a meth market, I want to recognize their demand in both the markets. Now, it's well known that drug and alcohol deaths were increasing before 2020. Less known but important for my purposes is that these deaths have a significant seasonal pattern. So that figure 2 in the paper includes dash series that show trends in seasonals estimated with data through 2019 and not beyond that. And then the paper focuses on the gaps between the solid and the dash, which are historically unprecedented and really large enough to show up in macro measures of health and longevity. The paper begins with a demand model, which I calibrate from studies conducted before the pandemic. There's one demand function for each of the 3 substances. Taking the income effect by itself, I assume the same percentage for each of the 3. Alcohol has its own price changes, which I relate to the shifting of drinking from bars and restaurants where alcohol is expensive to home where alcohol is much cheaper on a per gallon basis. That shift is less relevant for dangerous illegal drugs. For them, I focus on the full price, which is the sum of the money price and an opportunity cost. Consuming these types of drugs uses up time to acquire, administer, and especially recover. A lot of overdoses aren't fatal, but you may end up as a hospital inpatient, for example. So the full price involves the value of time, which is where the unemployment bonuses come in. Unemployment benefits have always been around, but what was novel in the last 2 years was to have the very large bonuses. These are policy-induced shocks to the value of time, in addition, of course, to other changes in the value of time coming from other sources. I need to tell you a little bit about the theoretical distinction between narcotics and meth, but I want to wrap up this slide by noting that the point here is to get quantitative predictions as to the contribution of income and a few price effects, and then compare them to what actually happened. Meth is a synthetic product. Narcotics and opioids specifically come in both organic and synthetic forms. The distinction between organic and synthetic is that farming is an important part of the production of organic products, the poppy fields in Mexico, for example. A synthetic product is made in a factory, perhaps a very small factory, but is essentially an industrial exercise using chemical ingredients that have many other uses than making opioids or meth. Therefore, synthetic drug supply is a lot more price elastic, also quite cheap these days. Whereas an increase in the demand for an organic product would be partially or perhaps entirely dampened by price increases, movement along an upward sloping supply curve, an increase in the demand for meth is not. That's what this picture shows. Opioid markets, you might say, are more interesting because the expensive organic products such as heroin or prescriptions that use the poppy plant coexist with the synthetic products, namely fentanyl and its analogs. In effect, supply slopes down. An increase in opioid demand induces some of the organic customers, or perhaps their dealers, to switch to cheaper fentanyl. It's the same analytic framework, really, that I use for alcohol, but there the switch, I said, was from bars and restaurants to homes. You might say that opioid demand shifts are amplified relative to what they would be with horizontal supply, which is what I've illustrated in the picture. So I assume the same underlying income and unemployment bonus effects for meth and narcotics, but the narcotics have those effects amplified. This approach has several predictions, and these are literally forecasts because my NBER working paper from exactly 2 years ago was all about this switching effect. And one prediction is that the organic opioid quantities would not increase and might even decrease during the pandemic. And this actually happened, at least as we measure it as deaths. Another prediction is that opioid quantities would increase proportionally more than meth. That's the amplifier I mentioned, even though the opioids include some categories with reduced quantities. Again, this fits the data. A numerical value for the opioid multiplier, if you want to call it that, was provided in my 2 years ago paper, and is used here in the demand modeling. The time that we have, let me show you the sum of the three model predictions, one for each substance. Namely, what do we expect to happen if we just had an income effect, a switching from drinking bars and restaurants to homes, and 2 episodes of unemployment bonuses? Of course, the second episode would have half the bonus of the first. And that's what I've shown here in the red series, which includes the trend and seasonal that I mentioned. The circles are the data, and they follow the same basic pattern. Both the amount of the increase, which is peaking twice at 180,000 annualized deaths, and the timing of those peaks. There's a lot more other patterns by substance, by demographic group, by time that are accurately predicted by the demand approach too. I will show you some of those on my last slide. In particular, let's take, if you look here at the end of 2020 and we see kind of a V shape or a U shape in the time series, let's look at that U shape and see whether it varies across demographic groups. This last part of the paper is a pure regression exercise. No calibration here. There's no use of theoretical restrictions. The mortality data, though, is separated by age group. And the regression residuals are normalized so that every age group is at the origin during the pandemic months with 0 bonus. And the dependent variable is the log of mortality from alcohol or drugs for those age groups and time periods. This means that time does not move monotonically in the picture. Chronologically, we start at the right. That's in April, May, June, July 2020. Then we go to the origin. That's the end of 2020. And then we go back to the middle when the $300 bonuses turn on again. The horizontal axis is the product of the statutory bonus amount, which is a national time series, and each group's UI participation rate, which is a cross-section variable. A 0.2, for example, means that either 10% of people were getting a $600 bonus or 20% of people were getting a $300 bonus. We see in this figure 8 that every age group has a U-shaped mortality series, except the elderly. And coincidentally, the elderly are the ones least exposed to UI. Now, perhaps it's all coincidence that actual mortality resembles what we'd expect from historical substitution and income effects. Certainly welcome other explanations for these patterns. But I want to end with noting that incentives really distinguish economic understanding from public health more broadly. And I think incentives here deserve serious consideration for the purposes of understanding the causes of drug and alcohol mortality. Thank you.